up with hypertension, where we looked at the epidemiology, the diagnosis, and the current trends in the management to prevent cardiovascular disease and CKD. Then last Tuesday, that's 2 days ago, we did updates in the prevention on and management of CVDs. Today, we want to look at a very interesting topic up with the updates, hypertension, where we looked at the epidemiology, the diagnosis, and the current trends. Sorry for the slight technical hitch. So today we're looking at updates in the prevention and management of diabetes in primary care. Today with us, we have great speakers. I'm sure you've heard them over and over again, but today they are here again to take us through this topic, updates in the prevention and the management of diabetes. I'm Dr. George Vediakunketi. I'm going to be your moderator, the president of the Society of Pharmacians of Ghana. We will zoom right in where we're going to have our first presentation. And our first presentation is going to be taken by my very good friend, Dr. Doa Eblogbe. There's a middle name, and those who know, but that is Obin. So if you happen to hear Doa Obin, most likely is my very good friend. So she is currently with the Trust Hostel. He's in charge of family medicine with Trust Hostel. She's a fellow of the West Africa College of Physicians. She's a senior specialist family physician, and she has a lot of interest in preventive medicine, especially cardiovascular diseases. And zooming in, her interest area is actually in diabetes. So today she's going to take us through the first topic, that is epidemiology, prevention, and diagnosis of diabetes. Currently, as we all know, the prevalence of diabetes is really increasing, a major cause of most of the cardiovascular diseases that we have. And one of the worrying areas is even in the CKDs, where we're having a number of cases secondary to diabetes. And most cardiovascular diseases also, being secondary to diabetes. We need to, at the primary care level, be able to pick these things up so that we can prevent the mortalities, the morbidities, and the mortalities that come through. My good friend will say that if you don't know, you don't know. And if you don't know, how can you manage? Today, Dr. Doa is going to take us through the epidemiology, the prevention, and of course, to be able to diagnose diabetes. Dr. Doa Eblogbe, kindly take floor. Thank you.
Thank you. Thank you very much for the kind introduction. And thank you very much, Dr. Inketia. Pardon. So sorry for the feedback. And apologies for the technical hitches. So good afternoon, and I hope you had a good lunch. I hope you can also see my screen. And I don't know whether you're aware of a Granny's International Football Tournament. We hear about the Black Stars, Black Satellites, and all that. We hear about our international competitions with the senior boys teams, senior girls. But I'm sure we've not really quite heard about the Granny's International Football Tournament. And who is this lady? She is a 67-year-old goalkeeper. And recently, they had a tournament in South Africa. She saved 9 goals, and the US of A won the Grannies International Football Tournament. Right, so let's begin with a case study. So let's meet Miss P.O., a 32-year-old with no chronic medical condition. She has a BMI of 40 kilogram per meter squared. Her mother has diabetes. She has a BP, a blood pressure of 130 on 80 millimeters of mercury. Her fasting plasma glucose is 5.9 millimole per liter. Her HbA1c when checked was 6%. A teller at a bank does not exercise or smoke. What would you want to know additionally about Miss P.O.? Well, the other additional history is that she had a baby 3 months ago, and the baby was large. And during her pregnancy, she had gestational diabetes. So we'll keep this in mind, and we'll go through this presentation. Good afternoon again. My name is Doregla Ogwe, and I'm taking you on the epidemiology, prevention, and diagnosis of diabetes mellitus. So I intend to inspire every one of us to lean more towards prevention of diabetes than cure. And these are my objectives. We would want to look at the epidemiology globally and locally. We want to recognize the modifiable and non-modifiable risk factors, look at some evidence-based data and strategies for prevention, identify high-risk populations, and look for the appropriate screening programs to use, and then take at least outline 4 practical interventions that we can take in our clinics, in our day-to-day offering of services to patients to delay or prevent type 2 diabetes. So my outline will go like so: an introduction, epidemiology, diagnosis, prevention, practical strategies, and barriers. So what is diabetes? And I'll run through these because I want my focus to be on the prevention. So it's a chronic metabolic disorder, and it's characterized by hyperglycemia. And this hyperglycemia is as a result of defects in insulin secretion, insulin action, or both. And we know there are 3 main types of diabetes. Type 1, where there's absolute insulin deficiency because of beta cell destruction, which is autoimmune mediated, and type 2 diabetes, which has a huge component of insulin resistance, and then gestational diabetes, and then the other specific types. So I'll run through the pathophysiology very quickly. And remember that in type 2 diabetes, there's some insulin resistance to kick off the process. So uptake of insulin, uptake of glucose by the muscle, by fat cells is reduced, and there's insulin resistance. To counter the effect of the resistance, the pancreatic beta cells would increase the secretion of insulin. And so there's a stage where there's excess insulin to help metabolize the glucose. And when, after a while, the pancreatic cells, the beta cells start to die off, and then insulin secretion wanes, and then there's hyperglycemia. Let's also remember with the ominous octet, where in the brain, there's some satiety issue, so people eat more, that in the liver, there's excess production of glucose when it's not needed. In the fat cells, there's breakdown of fat. The glucose uptake of muscles is reduced. Glucose-dependent incretin function is also impaired, as well as increased reabsorption of glucose from the glomerulus. And then, to top it off, glucagon secretion also increases. So we also know that diabetes is a fine balance between the environment and genetics. And if you look at this tug of war, which of them will win is which weighs higher. So sometimes people ask, does obesity run in families? And someone says, obesity happens because no one in the family runs. And the balance is what will determine whether there's going to be diabetes or not. Let's also remember that beyond the hyperglycemia, there are also oxidative stresses, there are inflammatory cytokines that occur in diabetes, and they are also responsible for the other cardiovascular effects that occur in diabetes. How bad is the problem? So, well, if you look at this picture, you see all the shades of pink, burgundy. These are problem areas. And if you see Ghana in there, it's a bit blue, not too dark, but it's quite blue. And it tells us that diabetes is a huge problem worldwide. The International Diabetes Federation puts the prevalence at 589 million globally. That's 1 in 9 individuals. So let's count the number of people on this call. Well, not that I'm a prophet of doom, but there may be a number of us living with diabetes. Then the challenging part is the prediction that is going to rise. The prevalence is going to rise to 853 million people just in 25 years. And if this is anything to go by, all the predictions have been exceeded. So this may just be an understatement. 4 in 5 adults with diabetes live in countries such as ours. And it's a huge cause of morbidity and mortality. 43% of adults with diabetes are not diagnosed, and 90% of them live in low and middle income countries. And 1 in 5 live births is affected by hyperglycemia. And over 75% of the diabetes-related deaths occur in lower middle income countries. And what's the major cause of diabetes deaths? Heart disease, stroke, kidney failure. So let's talk about Africa briefly. In Africa, about 25 million people have diabetes. This number is predicted to increase to 60 million by 2050, and that's about 142% rise. And this is going to be the highest in all the IDF regions. Well, I don't intend to upset anybody, but, is diabetes black or white? So before, we used to think that it was a white man's disease. And most people would say, oh, I don't know. I mean, diabetes is not a black person's illness. It was imported and all that. Does the data show that? Let's see. So in Ghana, in 1958, Dodu SR did a study on the incidence of diabetes, and it was 0.2%. In 1970, Akins et al. Did a literature review, and included in these studies are studies by Poby et al. And they put the prevalence of diabetes at 0.4 to 0.5%. In 2006, Addo et al. Did the same study and found out that 9.1% of individuals had type 2 diabetes, and a huge 17.4% had impaired fasting glucose. Yes, granted that the populations were different, but it shows that there's been a systematic increase in the prevalence. Recently, a systematic review done by Boahing et al. Puts the prevalence at 6.4%. Depending on which literature you're using, and even globally, you would find either males, more males or more females are affected. But in one study by Kazibwe in Ghana, more females were affected and more urban folk were affected compared with rural folk. And if you go to any district hospital, tertiary facility, you are likely to find that diabetes and its complications account for the rank as the third or fourth of the causes of morbidity and mortality in our facilities. Okay, a picture is worth 1,000 words. So please put in your chat box what you can see. I'll give it 30 seconds. 30 seconds. Please put in the chat box what you can see. Am I able to? Right. Someone says obesity, sedentary lifestyle. Someone is also saying there's an echo, if you can help us with that. Okay. Eating junk food, an obese person, an obese man on a couch with truncal obesity consuming junk food. Thank you very much. So this is one of the big concerns where type 2 diabetes is concerned. And one of the major drivers of diabetes is obesity. So obesity is responsible for about 217.6 million cases of type 2 diabetes. And unfortunately, our children are not spared. And the rates of obesity in childhood are doubling every 10 years. And in the clinics, you see young people with type 2 diabetes. If you're obese, you're 7 times higher at risk of getting type 2 diabetes than someone with normal weight. And there's going to be a double epidemic if it's not there already. By 2030, which is just in about 5 years, 1 in 5 women will be obese, 1 in 7 men will be living with obesity. So I think the problem is really huge. All right, I want us to remember this iceberg. And anytime I see this iceberg, I remember Titanic. So we see the tip of the iceberg, and these are the diabetes and impaired fasting. These are the diabetes prevalences we see. But beneath is the huge undiagnosed cases, huge impaired fasting, and huge impaired glucose tolerance. And the huge problem is that 78.7% of individuals in Ghana are undiagnosed. All right, so what does this information offer us? One, we have a problem. Please put in your concerns with what I've just discussed with you. And then what is the need here? The problem is that many of us have no idea that there's anything wrong with us. So we are at risk of cardiovascular disease, chronic kidney disease, retinopathy. And the need is that we need to identify and prevent such cases from progressing, sorry. Diabetes is not good for the pocket either. And several estimates in studies I've seen in Ghana show that there's quite a huge sum of money when pumped into diabetes care. Right. So if you are still with me, please put in the chat box what the main causes of morbidity and mortality in diabetes are. Now, let's go through the risk factors very quickly. I want you to make this personal. Ask yourself what you're doing currently, which would increase your risk of type 2 diabetes. And I found this risk assessment tool. It says, how old are you? If you're more than 40, you're in trouble. If you're a woman, if you're a man, you're in trouble. If you're a woman who has had diabetes in pregnancy, you're in trouble. If you have a father, mother, sibling with diabetes, you're in trouble. If you've been diagnosed with hypertension, you're in trouble. If you're physically inactive, you're in trouble. And if you're obese, more trouble. So put yourself in this and let's know what your risk is. So run through what we know already. genetics plays a huge role in type 2 diabetes, family history, ethnicity. So diabetes is more common in minorities. Obesity, which is central, and I've highlighted lifestyle, diet, and poor sleep because now poor sleep is known to be one of the risk factors as important as lifestyle and diet. Gestational diabetes, medical conditions. And if you have a parent, one parent with diabetes, you have a 2 to 3-fold chance of risk of getting diabetes. And if you have two parents, if both parents have it, and then the risk increases 5 to 6-fold. Right. In Ghana, in Asamoah Boahing's study, the risk factors which were important were family history, physical inactivity, and an age more than 40 years. How do you diagnose diabetes? We know already that would need a fasting plasma glucose or a 2-hour oral glucose test, a glycated hemoglobin, random glucose if you have classic symptoms. And I'm not going to go into the details of this, just to show that currently, if you have a standardized glycated hemoglobin assessment, it's preferred because it's a better indicator of chronic glycemia. But let's remember that it depends on hemoglobin. And so in cases where hemoglobin red cell turnover is a problem, we wouldn't be able to rely on it so much. Pre-diabetes, and I want us to pay particular attention to this. So pre-diabetes is diagnosed as an A1C of between 5.7 and 6.4%, a fasting plasma glucose between 5.6 and 6.9%, and a 2-hour post 75 milligram of oral glucose load of 7.8 to 11 millimole per liter. Now let's remember that before these start to rise, your postprandial glucose would have started to rise anyway. And by the time you get pre-diabetes, your beta cell function is on the decline. How do you prevent diabetes? Okay, so I know I'm here with my big brother. He's going to do most of the secondary, tertiary, quaternary. I will just focus on primordial and primary prevention of diabetes. So what does the evidence show? Do you remember what this is? Pink sheet. Okay, so let's look at evidence-based diabetes programs, and we know them, the diabetes prevention study, the diabetes prevention program. And just a very brief overview. So the diabetes prevention study was a Finnish study. Over 500 individuals were recruited. The BMI was in the obesity category as one. For the diabetes prevention program, more than 3,200 individuals with obesity and impaired fasting glucose were randomized into either intensive lifestyle modification or a control group and an additional metformin plus education group in the diabetes prevention study. And the results were remarkable. I'll just say that at the end of the first study, the diabetes prevention study, there was a 58% reduction in diabetes incidence, okay, compared to a 36% reduction in the intervention and control groups respectively. The diabetes prevention study had to be halted because the evidence was so overwhelming that they had to now put the people who were being deprived, so to speak, of the proper treatment, the appropriate treatment on the evidence-based treatment that was found to be appropriate. And this is just in pictures. Lifestyle tops it off. Metformin and some diets, definitely, but as you can see, placebo, no way. And After the diabetes prevention program, people have been followed up over 20 years, and that's a diabetes prevention outcome study. And the effects of lifestyle are still prevalent, with less and less people reporting to have developed diabetes, followed by the metformin group. Right. So how do we prevent diabetes? There's some data to indicate there are trials on type 1 diabetes prevention. I'm not going to go into that. But the IDF has proposed a 3-step plan. So number 1, identify those who may be at increased risk. Identify the iceberg, risk evaluation, and then intervene to prevent diabetes. So we screen, and to screen, we need to identify, the screening is aimed at identifying high-risk individuals, and we'll go through the screening tests. So who do you screen? If you have any risk factor, so by now we've gone through a lot. If you have any risk factor, you're an adult, please, you need to be screened, you need to screen your patients. If you are fortunate not to have any, then you can start at the age of 35 years. But if you have pre-diabetes, screen annually, before pregnancy, during pregnancy, if you've had gestational diabetes, if you've had hypertension, if you have hypertension or pre-hypertension, if you have dyslipidemia, if you have cardiovascular disease of any kind, if you have retroviral infection, you need to screen. And then women with polycystic ovary syndrome, and metabolic syndrome, you need to be screened. And other conditions, acanthosis nigricans, you need to screen. So I found this in the Ghana Diabetes Guidelines for adolescents. So screening for adolescents, it starts from identifying whose parent, a mother who has had a history of diabetes or gestational diabetes. So you should screen children like that. You should screen those who were large for age. You should screen those with acanthosis nigricans, which signifies insulin resistance. We should screen those with a family history of diabetes, overweight and obese youth. And the question I ask is then who shouldn't be screened? Right. So I wouldn't go through gestational diabetes, but since family physicians see patients who are pregnant, we should know that we need to screen them as well. So what do you do when you find someone who has pre-diabetes, impaired fasting glucose, as we discussed, or impaired glucose tolerance? Please do not wait. Let's not wait for them to clock 7 and say, yes, now you have diabetes. Let's manage you. Let's manage aggressively. So how do we manage? Lifestyle interventions. And all the studies have shown that if you lose weight, at least 7 to 10% of body weight, you are likely to stall the progress from pre-diabetes to diabetes. And the interesting one is that with every 1 kilogram weight loss, you reduce your risk of diabetes by 16%. And that's quite heartwarming with all the sad things I've been saying this afternoon. So what do you do as well with your diet? And anytime we talk about diet, we get we go into a frenzy because we feel that we don't have the appropriate ingredients for a healthy diet in our country, but that is far from true. So if you look here to my left, that's the typical Mediterranean diet, grains, nuts, seeds, greens, vegetables. And then if you look to my right, we see things that are a little more common: peas, onions, green beans, peppers, pears, cauliflowers, etc., cucumbers, and they are prevalent in Ghana. It's just that they're pricey. So we can do other things. We have all these nuts and seeds: sorghum, millet, brown rice, corn, peas. And then we have these varieties of greens. I don't know how many of us know these ones: kontomire, water leaf, bitter leaf, amaranthus, alefu. We have a variety which we can choose from. What does the International Diabetes Federation recommend? It says you should drink water or tea or coffee and not sweetened sugar beverages. If you need to eat bread, then eat whole wheat bread. You know, this grainy one, you definitely can't eat much of that. And then you should eat at least 3 servings of fresh fruits and vegetables every day, including green leafy vegetables. And white meat is preferred as well as fish, but they should be lean, thin portions. And then if you need to do rice, do brown. If you need to do any yogurt, do unsweetened. If you need any spread, do peanut butter instead of butter and the others, jam, etc. Definitely no chocolate spread. And if you need to do oils, olive oil, canola oil are preferred. Walk. Okay, I should have been doing this standing because you should take the opportunities to stand. So actually, when I came, I was prepared to stand, but so stand, walk, take the opportunity, climb the stairs, and then engage in physical activity. And the catch is at least 150 minutes of brisk walking in a week, at least, meaning that that is the minimum. And then you need also some muscle strengthening exercises. You can also purchase for yourself pedometers or ask your patients to have accelerometers, pedometers, and these smart apps that can measure what you're doing. Sleep. So sleep has become a problem. We live far. We have to wake up early. We wake the children up and we get home very late, and sleep is a problem now. But if you sleep well, you are able to mitigate the effects that diet and exercise have. Let me take that again. Exercise and diet rather mitigate the effect of poor sleep, but that is not to say don't sleep well. Are there medications that we can use? Yes, but there are indications for using medications. So, and we'll come across that shortly. So as in the study, we realized that metformin was used. And then for those who are obese, you can also use GLP-1 agonists. The bedrock is still non-pharmacological. So you're not going to give them these medications and say, that's it, you're not going to get diabetes. No, the bedrock is non-pharmacological management. And who do we give the the metformin? So individuals who are less than 60 years of age, BMI more than 35 kilogram per meter squared, history of gestational diabetes, and you have impaired fasting glucose or impaired glucose tolerance. You do lifestyle modification and you can add metformin. This also has to be individualized. So what are the practical strategies to prevent diabetes? So we look at an individual level. We screen, we do our lifestyle counseling, use behavior change communication methods, motivational interviewing, use technology. So at a facility level, how do we coordinate care so that we don't lose out on the large numbers of people who have impaired fasting or impaired glucose tolerance? Our concentration should not just be on people with diagnosed chronic medical conditions, but we can track all those who have impaired fasting glucose or pre-diabetes using LIMS, using our electronic medical records, and intervene. At the community level, I'm not very aware of exercise programs, but well, I think the opportunity is there for us to start something. And then primordial prevention, that is more of a policy-based issue. So how do we approach counseling an individual? We can use several tools. We can use a 5A tools. It's just one of the many, many tools. And then sometimes you can have these leave outs, handouts in your waiting area, or you can have some discussions before, patients get to see a physician. This is a chronic care model by Wagner et al. That can also be used in getting a service which will cater to the needs of people with pre-diabetes. Technology. Can we please put in the chat box what you think technology can do in preventing type 2 diabetes? So please put in. So let's bring it home. I've been talking for a while. I don't know do I have any time for people to contribute? 5 minutes, that's small. Okay, so please put in your chat box. Bringing it all home. Lifestyle intervention, pharmacological interventions, public health strategies. I wanted us to have a discussion, but I have very little time. So there are some answers. Okay, apps to encourage. It's going so fast. Insulin checks regularly when alerts for hypo and hypoglycemia. I don't understand that. Can you please explain? Wearables can be used. Thank you very much. Okay. So community-based interventions. We live in a country which, we still have good settings for community mobilization. So we can mobilize communities, we can have DERBs, we can have educational programs for communities. And then at different level, using the ecological model, we can have support groups, workplace wellness programs, and then use of social media. How about that? Can we change our eating? Can we change what it means for a Ghanaian to look good? I don't know whether you know this tree. It's Acacia. And these are some of the areas we can do community mobilization. Now for primordial prevention. Well, family physicians are also advocates, aren't we? So we can advocate for increased taxes on sweetened sugar beverages. We can advocate for work-based, hospital-based exercise programs and community programs as well. Right, so please just, this is a busy slide, I apologize, but I've highlighted a few things. And we are family physicians, and what we hope is to strengthen primary healthcare to improve early diagnosis and prevention of complications of diabetes. And then for those in policy making capacity, want to strengthen political commitment to address obesity and ensure that the efforts are cross-departmental and sectorial, sorry. Empower communities and patients to strengthen their engagement in healthy weight promotion. So family physicians, this is what we do, and we are best placed to tackle the problem of diabetes. So what are the barriers? What are the barriers? Why are more people in the impaired fasting and impaired glucose tolerance groups? What are the barriers to diabetes prevention? There may be personal barriers. We are not motivated. We don't have time. Or do we? We never have time for anything. Social cultural concepts on weight. If you are around, you look good. Your wife or your husband is feeding you and providing well for you. If you lose a little weight, your wife or husband is in trouble. When we are affluent, what do? We eat out. How about the cost? I mean, definitely vegetables and these other grains are not very cheap. So I'm reliably informed, though, that Dr. Nketia has provided us with corn on a cob and a slice of orange for our lunch. Instead of our usual fried rice and chicken. I don't know how many of you are very excited about that. The other big barriers are external. So funding. So these diabetes programs that were, population-based received funding. Are we ready to put our mouths where money where our mouths are? One of them. Resources. And then health infrastructure disparities. Social cultural norms, which I've talked a bit about. And then education. And that's what we are doing. One of the things we're doing. So let's go back to Miss P.O. Are you in a better position to offer Miss P.O. some care if she came to you? 32 years, no chronic medical condition, BMI of 40 kilogram per meter squared. Mother has diabetes, her blood pressure is 130 on 80 millimeters of mercury, fasting plasma glucose and HbA1c in the impaired range, the pre-diabetes range, no exercise, and a sedentary lifestyle. I cannot end without saying anything about children because unfortunately now children are very sedentary. They don't go out and play football. They don't go out and run around with their friends. Well, we claim, and to an extent, our environments may not be that safe, etc. There's a lot of pollution. But some studies showed that the usual playing in children, physical activity, reduction in sedentary time, and diet can also affect children positively. So let me leave you with a 14-year-old who has a BMI of 35 kilograms per meter squared, who weighs 78 kilograms. And these are not anecdotes, they are real people. Mother has type 2 diabetes, has RBS 33.3, and has a tablet. That's not medication, by the way, and a very healthy appetite. I'd want to end here and say Asante Sana, Milo Brara in my Siwu from Lolobi, and I'll pause for questions, comments. I'll acknowledge these people, and then my references follow. Thank you very much.
Thank you very much, Dr. Dora Eblogbe. She's taken after one of her mentees, which we saw the picture. Just that she's not been able to attain the size of a mentee. Thank you very much for this particular one. A few things that she talked about: prevention. And the question is that if you're at your facility, a primary care facility, are you able to diagnose diabetes? Are you always looking at diabetes and not pre-diabetes? Because one of the stages that we can really help them to prevent them from getting there is catching them at that point and trying to prevent it. And even better, knowing the risk factors and managing those risk factors so that they don't even get there. Thank you very much, Dr. Dora. And I'm proud to say that we have some great partners with us. That's Get Pharma. Since they came into the country, they've been great partners, partnering with us to bring a lot of education, as Dora said to you. Get Pharma, thank you so much for this partnership. And I know that this partnership will grow and become even better. Next on bill is my very good friend, Dr. Francis Ade. He'll be taking us through current guidelines in the management of diabetes in primary care. Dr. Francis Ade is a family physician and a diabetologist. Currently, he works with Focus as a consultant and a head of medical services. He's a trainer, a researcher, and an advocate of quality care and patient safety. And he also helps in developing a lot of guidelines for NCDs, diabetes, hypertension at the primary care level. We've done a lot of work together. Today, he'll be taking us through, as I said, the current guidelines in the management of diabetes in primary care. Dr. Francis Ade, kindly take the floor. Thank you.
Board President. And I want to say good afternoon to my fellow panelists, a dear sister who I admire so much, Dora, for that wonderful and excellent presentation. And our participants online and our sponsors. And again, I want to say a big thank you to the executive body of SOFPOC for calling on me to be part of these updates. I think Dora has touched on primary prevention, and my focus will be more in the area of secondary and then tertiary. So for those who have been diagnosed with diabetes, what do we do? And that is what I'll be looking at. And I must say that my presentation is going to be more evidence-based because we have different guidelines. I mean, as a country now, we have our own diabetes treatment guidelines. We have the ADA, we have the ESC, we have the European Association to the Study of Diabetes, we have international bodies like IDF. So looking at them, I just focused on the standard treatment guidelines as far as 2025 is concerned. And I compared what IDF has come up with and what ADA has come up with. And most of them are similar. So I'm going to concentrate more with the ADA 2025 standards of care when it comes to diabetes. I must say that I'll be leaving out type 1 because of time, but I'll be willing to answer questions in that regard. My concentration will be more of type 2. So this will be my objectives: to introduce healthcare providers at the primary care level. And I must say that primary care is not just at the district level. You may even be in a quaternary center, but still have a primary care service within a quaternary center or a tertiary center. And then my second objective will be to provide clinicians and then other healthcare providers, including patients, with components of diabetes care and general treatment goals. This will be my outline of presentation. We'll look at what goes into comprehensive medical evaluation and assessment of comorbidities when it comes to diabetes. My second outline is something I'm going to really emphasize on, because most of the time we tend to be more glucocentric. We do very well to control their blood pressures. We do well to control their lipids, and we leave out a lot more. And in our assessment, I'm going to mention some of those pitfalls. I mean, I must agree. I've been practicing diabetes for so many years, and to be honest with you, sometimes I leave some out myself, especially when you have a heavy clinic day. But these are things that we have to pay attention to. My second outline would be the current recommendations, as my president rightly said, in the management of diabetes and its comorbidities. And then we'll have a take-home message. Like I said in my earlier submission, most of the things I'll be talking about will be evidence-based. And I just want to take us back a bit. When we look at evidence-based medicine, we look at it at 4 different levels. Level A, B, C, and then E. Please remember, there's no level D. Okay. When it comes to level A, which is the strongest evidence, you're looking at reviews, you're looking at meta-analysis of well-conducted randomized controlled trials. Level B, more of cohort studies. And then level C, you're looking at case series, not well, or let me say poorly controlled studies. And then the E are the expert's opinion. So for each standard of care or for each management recommendation that I'll be making, you will see these references, either a B, an A, a C, and then an E, so that you make informed decisions when it comes to the standards of care in diabetes. Comprehensive medical evaluation and assessment of comorbidities. Management of every condition medically start with detailed history taken. In fact, if you miss your history, or if you need that detailed history, you've missed out a lot. And in evaluating our patients with diabetes, it goes beyond glucosentrinism. It goes beyond blood pressures. There are lots that we have to, in the area of social history, in the area of family history, in the area of psychosocial issues, we have to tackle all of them, and I'll be taking us through them. In Dora's presentation, she made mention of open-ended style of counseling and then how to take history. I must say that when it comes to diabetes care, it should be a patient-centered approach to care, where you put a patient at the center. I must also say that it's a team-based approach to care. So it is not just the physician who is attending to the patient living with diabetes. You need the nurses, you need the rehabilitation experts, or we call physiotherapists, you need the pharmacists, you need your dentists, you need ophthalmologists. If you don't have podiatrists, you can train your nurses to inspect and then look at the feet of our patients with if you are fortunate to have a mental health expert, then you are blessed. But what I'm trying to point across is that it's a team-based approach, and it has to be patient-centered. And when we talk about patient-centeredness, you are putting the patient first. You're trying to assess the patient who is presenting to you with diabetes and not the diabetes. So your attention is not on the disease condition, but then your attention is on the patient as a whole. So you go beyond the medical condition, which is just the diabetes, and then go more into the psychosocial aspect, the holistic approach to care that we talk about. So it should be patient-centered and it should be team-based approach. Goals of care. I must say that diabetes care has moved from just glucose lowering care, but there are standard goals of care, and these goals of care, it's cyclical. So at one point in time, you may have certain omissions or you may have a patient relapsing, but you always have to come back. What is key is the initial assessment of the patient before you. So you want to find out the diabetes state of the patient. You want to find out the ideas from the patient as far as diabetes is concerned. You want to find out if the patient has other comorbidities beside or beyond the diabetes. So you're talking about cardiovascular complications, you're talking about chronic kidney diseases, heart failures. You also want to find out if the patient has other psychosocial issues. So the initial assessment of the patient is key, and it has to be holistic, because if you leave some out and you become glucocentric and your attention is just to lower the sugar, meanwhile that patient may be having a stage 2 or stage 3 CKD, either 3A or 3B, and you fail to assess this from the initial the initial assessment. And let's say a stage 3B, you put a patient on metformin, you're going to tip that patient more into a stage 4 or even a stage 5, which is end stage. So the initial assessment is key. And then you also have to consider specific factors that impact the choice of treatment. So you want to look at the socioeconomic status of the patient is very, very important, because if you write a medication for a patient who cannot afford it, you've not helped the patient in any way. So the social determinants you need to find out from the patient. Is the person earning an income? What are the social support systems that the patient can derive? You also want to use what we call shared decision making, which is more patient-centered. Okay, we want to ensure that the patient has access to diabetes self-management and education programs, as Dora mentioned, as part of the preventive measure, because we know that a patient who lives with diabetes, who is well informed or who is well educated and able to take care of themselves, they end up living longer, unlike those who are not well informed or not well educated. And again, after all your assessment, and then you know the patient before you, and you know what to do for the patient and all that, you need to agree on something now, which is the fourth step. The fourth step is that you have to agree on a management plan. And at this management plan, you have to set clear goals. What are my, let's say, glycemic goals for this patient? What will be my A1C target for this patient? What will be my LDL target for this patient? Will this patient benefit from drug A or drug B? And these goals must be agreed on with the patient. And they must be very, very smart. Okay. They must be specific, measurable, achievable, and realistic. And of course, should be time bound. The fifth pillar, again, is that you implement and then monitor and then review your management plan. Like I said, it's a cyclical thing. And these are the standards. We need to go beyond glucosentrism. We need to go beyond BP control and look at the patient as a holistic individual and not just the diabetes that the patient is presenting to us with. When it comes to comprehensive medical evaluation in terms of history taking, what has evidence shown us? Evidence has shown that the first thing is that you need to confirm the diagnosis of the type or classify the type of diabetes you are dealing with. I've had the opportunity of managing patients who unfortunately were misdiagnosed with type 1 diabetes, who clearly had type 2 diabetes. Okay. So you need to know the patient before me, whether an adult, an adolescent, or whatever. Is it a type 1 that I'm dealing with? Is it a type 2? I appreciate the fact that we may sometimes find ourselves in low resource environment where some of these tests may be challenging, and therefore classifying the type of diabetes before us may be a challenge or may throw some challenge to us. But please, let us try. If from the onset, you have to refer a patient to a level or another facility to get the classification right, please let us do that. If it's type 1, it is type 1. If it is type 2, type 2. If it's another form of diabetes, so be it. This will inform how you're going to manage your patient. So if you fail to classify the type of diabetes, you've missed out a lot. And you see the rating of evidence there is A. And that is what has been proven. So if you fail to classify and you manage a type 2 like a type 1, right from the onset, you put a patient on insulin, you're not helping the patient in any way. And remember, insulin is an anabolic steroid, let me put it that way, and the patient will definitely gain weight. The second most important thing is that you have to assess the glycemic status of previous treatment, what we call medication reconciliation. So the glycemic status from the onset will let you decide whether this patient will need monotherapy, will need dual therapy, will need triple therapy, or even my dual therapy from the onset, I need to, or triple therapy, I need to add insulin or maybe add an injectable. It's very, very important. The third point is that you have to evaluate for diabetes complications. You need to look out for the microvascular and the macrovascular complications and other potential comorbids. Again, the level of evidence there is A. Okay. So comprehensive evaluation right from the onset is so important. And then with all that done, you develop a plan. Continuity of care is so key. So it has to be very, very comprehensive. You don't have to leave anything out. So now let me come to the pitfalls. And I identify these pitfalls because in practice and in my trainings, I've realized it's something we don't do often. We have our attention most of the time is in children because we know our expanded program on immunization is something we uphold. But when it comes to adults vaccine preventable disease, we don't pay much attention to. And we know that patients who live with diabetes, if they should suffer any form of chest infection like pneumonia, it tends to be very, very severe. Fortunately for us, we now have pneumococcal vaccine around. We have the Prevnar 13, and I'm happy we had to push for this. But how many of us in our initial assessment of patient try to find out whether they've had any form of immunization? Most of the time, we don't ask them. But I must say that in patients living with diabetes, vaccine preventable diseases like pneumococcal pneumonia, varicella zoster infection or reactivation, we can prevent them. We now have varicella vaccine around. We now have Prevnar around. So the immunization history should be part of the initial assessment. And if you find the gaps, please, just a single shot is enough for the patient, okay? Autoimmune diseases. If you fail to classify your diabetes to tell whether it's a type 1 or type 2, for every patient with type 1 diabetes, you have to screen for other form of autoimmune diseases, especially autoimmune thyroiditis. It's something that you have to. If you're dealing with an adult with type 1, then you have to rule out or screen for celiac disease. Unfortunately, we have labs around who can do these antibodies for us. You can even ask for endoscopic biopsies and you can have them carried out for you. These are so important because if you miss out on some of these other comorbidities associated with type 1, you end up not helping the patient. Bone health. It's unfortunate as a country, we are not able to have access to DEXA, especially for our menopausal women who live with diabetes. So the second point may not be so applicable, but it's very, very important. Beyond diabetes, once you're dealing with an elderly patient, 65 years plus, bone mass is something that you have to assess. But the first point in assessing bone health, we can do it. Assess fracture risks. So risks of fall. You have a patient who has a long-standing history of diabetes with some form of Parkinsonism from maybe a vascular Parkinsonism because of the long-standing of diabetes and its complications. That patient is a high risk of fall, and that patient can fracture a bone. So with simple assessment and questioning, you'll be able to tell who has that risk of fall and therefore fracture. Okay, the bone mass may be a challenge because in country, we don't have DEXA available, but few questions will help. Visual impairment, they are all at risk of fall. Okay. Again, what we often miss in our initial assessment of our patient, assessing their cognitive function, most of the time, we don't even ask whether they are able to perform activities of daily living, whether they're able to perform advanced activities of daily living. Simple mini mental state assessment will let us know that I may be dealing with a patient with cognitive impairment. A patient with cognitive impairment definitely needs assistance. You are prescribing insulin, but basal insulin for an elderly patient without assessing cognitive impairment. You've written it all right. Maybe you said 10 units or 12 units. The patient may end up taking 20. Next thing is he or she is in hypo and is gone. Okay, so cognitive impairment, especially in our older patients, in our initial assessment, we have to, okay, dental care. Diabetes with reduced immunity predisposes our clients to dental caries and all that. We need to find out in our medical assessment whether the patient has ever seen a dentist before. If not, we have to find a way to refer them. Disabilities of any form, we have to assess this. Okay, so the history and initial assessment goes beyond all about glycemic control. We have to do a detailed job. another big issue, sexual dysfunction. I must say that is an area where a lot of healthcare providers shy away from. And this is a topic where patients themselves don't bring up, but it's very common. Diabetes in itself, from its microvascular complications and macrovascular, one of the three microvascular complications tend to be peripheral neuropathy. And macrovascular wise, especially in men, we know that the phallus has no bone in it. What makes it turgid or what makes it strong is vascularization. So diabetes in itself can cause a lot of sexual problems. Women in their menopausal age, of course, poorly controlled diabetes with affected secretory cells and all that, dryness, genitourinary symptoms of the menopausal, making it worse or complicating it. So we have to find out. And I'm going to show some two studies, one done in Ghana about some 16 years, and then a global one in about 2 years. This is very common, and it should be part of our initial assessment. If we are fortunate, a female who lives with diabetes and being seen by a female doctor, she may be more comfortable to talk about it, okay? But if a female patient is seeing a male doctor, they are not likely. I think the other way around also applies, where a male who has diabetes is seeing a female doctor, he's not likely to talk about it. So we have to know that this is very common, okay? Simple questions. There are even three tools that you can use, but simple questions. How is your sexual life? Do you get aroused? Simple things. Do you get the edge? I mean, those simple questions can help, because if you don't deal with it, it compounds. Diabetes in itself is stressful for the patient. It compounds their psychosocial problems and it affects their general well-being. So sexual dysfunction is something that our initial assessment, we really have to look into it. So this is the global review I was talking about. And this is a paper that was published about 3 years ago. You realize that the prevalence globally, the prevalence of sexual dysfunction among patients with diabetes is around 61%. 61%. And so you're looking at 6 out of 10 patients living with adult diabetes having some form of sexual dysfunction. Even though the highest prevalence was found among Europeans, it cuts across globally. So it's that common. Let's come down to Ghana. I didn't find too many studies, but I found one. Fortunately, a colleague is working on something, and I know by 2026, we'll have a paper out on this. But in Ghana, this was Oredu et al. Was published somewhere in 2011, and they found sexual dysfunction among patients within Accra was around 69%. So you're looking at almost 70%, 7 out of 10 patients with diabetes who have some form of sexual dysfunction. And their findings were comparable with a previous study that has been done in the southern sector, mainly in Ashanti region. This was purely within the Greater Accra region, Tema, and then some aspect of Accra. So sexual dysfunction is quite common, and it has to be part of our day-to-day assessment of our patients who live with diabetes. Another pitfall is the area of assessing what we call metabolic associated liver diseases, okay? The old terminology used to be non-alcoholic fatty liver disease. We know diabetes itself causes hypertriglyceridemia and causes very low HDL. And so when you talk about, let me borrow the old terminology, fatty liver disease, diabetes itself is a cause of fatty liver disease, obesity, and of course, hyperlipidemia. These are the 3 common causes of non-alcoholic fatty liver disease. The preferred term now is metabolic associated steatosis liver disease, or we call the MASD. Okay, with inflamed liver leading to raised transaminases, then you're having the steatohepatitis, or we call MASH. This is something that we have to screen for in our initial assessment of our patient. Most of the time, we don't do it. We are good at doing this in patients who are alcoholic or who have what we call alcohol use disorders. Okay, but in our patients who live with diabetes, we have to. We used to use the APRI, what we call the aspartate platelet ratio index. The preferred calculator or tool now is the fibrosis 4 index, where you input 4 parameters. It's age related, your AST, your ALT, and of course your platelet. So it will give you a score, and that score will put a patient in no or minimal fibrosis, that is looking at F0 to F1, or you have some form of moderate fibrosis, looking at F2 to F3, and then cirrhosis, which is F4, and that is the severest form. We have to assess this, okay? If there's a need, just asking for a hepatic function panel, or we call liver function test, will tell you. And of course, you need to, irrespective of the transaminases, you have to do a full blood count or a complete blood count, get your platelets, get your AST, get your ALT, input the age. With this 4, you get a score. And this has to be done annually. In fact, if you do and it's abnormal, you can repeat it in 6 months. But if you don't do this, when we come to the management, you realize that even your choice of drugs may be wrong for the patient. And in prevention of secondary and the tertiary level, you'll be missing out. Because if a person has some form of metabolic associated liver disease and you just go and choose metformin for that patient, whilst you could have done a GLP receptor agonist, for example, from which the patient will benefit, then you wouldn't have helped the patient in any way. So in our initial assessment, doing just a liver function test may not be enough. You need to input it into your fibrosis 4 index calculator to generate a score for you. And all you need is you input the age of the patient, your AST, your ALT, and of course your platelets. Okay, so you get a score. And we have to assess this right from the beginning. It is very, very important, because if you don't, once a patient has a metabolic associated liver disease, their risks of cardiometabolic complications tend to be very, very high. So this is what I was alluding to. Once you do your scoring so well, okay, you'll be able to decide which management plan you want to institute for the patient. So when it comes to the management, it is important that lifestyle cuts across. In fact, for MASH and MASH, medications are there, but what has been proven by evidence is lifestyle. And in primary prevention, I think Dora did justice to the lifestyle. So activity level, diet. We are what we are from what we eat. Diet is everything. Okay, plays a major role. For those who, you have to definitely bring in some pharmacotherapy. Then the glucagon-like peptide are the best. These are injectables. You can actually combine. Now we are allowed. It's unfortunate we don't have a lot of the GIPs around, but we have the GLPs, receptor agonists around. And the good thing about them is that some you can even give it as a weekly shot. Okay. So you don't choose metformin for such patients from the beginning, unless of course the A1C is such that you need dual therapy. Then you use a GLP-1 in addition to metformin. But metformin is definitely not the first line for such patients. Okay, I think I touched on this earlier. So depending on the score, you decide on In my intro, I made mention of the team-based approach. Some of the cases, especially those with F2, F4, you may have to bring on board the gastroenterologist, okay? And the level of recommendation here is an A. So the team-based approach is so important. Okay, so you bring in the expertise of others. If it's just F1, F2, you can handle. But once it's F3, F4, you definitely need the input of a gastroenterologist. Okay. All right. Touch on this. What I need to mention is there's room for bariatric surgery for some of these patients, especially the morbidly obese patients with metabolic associated liver diseases who have diabetes. And the recommendation is once the BMI usually more than 35 thereabouts, you can recommend surgery for them. Okay, so this summarizes all that I've said. Depending on the stage, for some of the patients, you may need obesity pharmacotherapy that is very early F1 thereabouts, like Orlistat. When it comes to handling the glycemia, you need your GLP-1 receptor agonist. Okay, for them, you need specific treatment for MASH. For those with moderate F2, F3, this is where the gastroenterologists come in. You need treatment for MASH, immune modulators like resmetirom. I don't have experience with that, but you need a gastroenterologist at this level. Of course, again, when it comes to your glycemic control, you need your GLP-1 receptor agonist. And pioglitazone plays a very good role. Pioglitazone, it's an insulin sensitizer. When it comes to metabolic associated liver diseases, they play a very, very good role, and they are better than metformin. So if the patient needs dual therapy, let's say you've seen a patient with diabetes, A1C is about 8.5%. Definitely that patient needs dual therapy. And if that patient, in addition, has some form of metabolic associated liver disease, your best bets will be a GLP-1 receptor agonist, which can be a weekly injection, and then your oral can be pioglitazone, and you achieve best outcomes for such a patient. We need to support patients with diabetes with positive health behaviors, health-seeking behaviors. What has been shown, Laura made mention of technologies, okay? Technologies are playing a good role, telemedicines and all that. I'm fortunate to have been part of a team who remotely attend to patients with diabetes and hypertension. We use an app we call the NCD Care. It's an app we use for COVID, but now we're using it in ND-Care, and it's really, really working. So remotely, and in our clinics, we can do this. You can do even Zoom, depending on where your patient is. Okay, you can use some technologies to support just for behavior change, reminding them that they have to be active, because a patient with diabetes shouldn't stay 2 days without any form of activity. Okay, so they have to be active, and we can do this. We have to support them. Diabetes self-management, education, and support. One of the authorities in diabetes, called Jocelyn, has a quote that the well-educated patient with diabetes lives longer. And it's true. A well-educated patient with diabetes may have to visit the hospital twice or once even a year, because they know what to do. They know what to eat, how much to eat, how to titrate their medications and everything. Okay. So this can be done at the individual level and also can be done in groups. We tried this in my early days in diabetes care. We formed the Kwelman Diabetes Association, where we met them every 40th day. And it really, really, really worked. I don't know the state of it now, but in our clinics, we can train some of our nurses. So at the time of diagnosis, there's an education plan for the patient, but it has to be reviewed. It has to be well structured. So it can be done at the individual level, and then it can be done within groups. You cannot manage diabetes with just pharmacotherapy. Education, reinforcement, behavioral change, reinforcement every now and then, that has been shown to work. And you can also support this with digital tools like apps, like telemedicine, and all that. And it really, really works. Medical nutrition therapy. Dora mentioned this in her earlier submission. Okay. For primary prevention of diabetes, the weight targets between 7 to 10%. But when it comes to diabetes control, a weight reduction of just 3 to 7% is enough. Okay. Of course, if they can achieve up to 10, the better. But 3 to 7%, again, the level of recommendation is an A. You cannot, I'm fortunate to have a well-built diet and nutrition unit, and they support us so well. So every patient with diabetes is referred to them. But if you don't have where you work, you can train some nurses to help with dietary counseling, portion size and all that. But it's an integral part of diabetes management that we don't know. Pharmacotherapy, can you hear me? Sorry. Okay. You can hear me. Okay. I'm sorry about the technical hitch, but because of time, we have to continue. So medical nutrition therapy is an integral part of diabetes care that we don't have to leave out. And if we do it so well, and we're able to attain a weight reduction of 3 to 7%, I believe it will go a long way to improve their glycemic control and, of course, prevent other complications that comes with it. If it is done well, I must say that it saves costs, okay? And then also it improves cardiometabolic outcomes. Remember that we are what we eat, okay? Physical activity, very sorry, my slide is a bit busy, but the bottom line is that a combination of moderate to vigorous intensity is just enough. And all you need is 150 minutes in a week. You can spread this as 3 days within a week. Okay. But a patient who lives with diabetes should not stay 2 consecutive days without any form of activity. We cannot talk about diabetes care and leave out smoke cessation. Any form of smoke. Now we've seen a lot of e-cigarettes. Okay. So any form of smoking, e-cigarettes are very common now. The shisha is not e-cigarette, but shishas and the cannabis use has become so common now. Please remember that nicotine is a vasoconstrictor, and patients who live with diabetes are already at risk of micro and macrovascular complications. And when they use tobacco, this risk worsens. And in fact, the cessation, if you look at the level of evidence, again, is A. Okay. So we have to encourage them. And remember, it's not going to be easy. It's not going to be easy. We always have to assess. We always have to assess which level of the change cycle they are. Okay. Dora gave us the 5 years of counseling. So you have to assess and then reinforce. And remember that they can relapse, but definitely we teach them and help them to come out of this. Psychosocial. This has become a big issue now, a big issue. Diabetes itself poses a lot of stress when it comes to the patient. So in assessing them, we have to assess their psychosocial well-being. Very, very important, because if you leave it out, if you think that you have to refer to a qualified person, please do so. So that the patient living with diabetes gets some psychosocial support. If you don't do it well, remember that you can even stay for weeks without adhering to your medication protocols. Sleep, 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 sleep. As part of lifestyle management, we have to encourage them. What is important when it comes to sleep health is the deep sleep, where you're looking at 1.5 hours to about 2 hours, very deep sleep, because that is when the tissues repair. Now we know that what we call the non-traditional risk factors, where a lot of inflammatory responses are stimulated. Poor sleep contributes that stress and all that. So good sleep goes a long way to help with their cardiometabolic control. So we need to counsel people with diabetes to practice sleep promoting routines and habits. And one of them is exercising, allowing yourself about an hour after a meal and doing about 30 minutes to 1 hour. Take a shower, your muscles will ache, and therefore you sleep very well. Okay. We try to help them reduce their screen time. Now people go to bed with their phones. And so with increased screen time, you can't sleep and sleep well. We teach them how to declutter. You don't put TV in your bedrooms. So they declutter, they try to turn off every device within the bedroom so that they can sleep well. We have to help them sleep well. Glycemic assessment and goals. This has to be done right from the beginning. You set clear goals. Is it a patient that will need dual therapy, monotherapy? What are the combinations that I have to use? Remember that for all the orals, the best gain in terms of A1C will be between 0.5 to about 1.5 max. So if a patient has an A1C at 10% and you choose monotherapy, you're not helping the patient. We now talk about early intensification. So combination therapy is the way to go, and you set clear glycemic goals, whether you do dual or monotherapy. One thing that has come up strongly is continuous glucose monitoring. Few centers in Ghana now have some devices, but the recommendation is more in type 1. So adults with type 1, and then of course, adolescents and children with type 1. Of course, some type 2s who are insulin augmentation with tighter control may need continuous glucose monitoring. Continuous glucose monitoring has a superior advantage over self-glucose monitoring. Time will not allow us to go through, but during question time, I'll be ready to answer any question. I must say that for some patients where A1C cannot be used, glycated hemoglobin cannot be used, fructosamine is expensive, but so when you take your patients with like sickle cell disease or any form of hemoglobinopathy, then your A1C will not work. Okay, in such patients, you can do fructosamine. Of course, if you have continuous glucose monitoring, that would be a good tool. And you're looking at your time in range being about 70%. What that means is that if they are doing continuous glucose monitoring, then 17% of the total 24-hour monitoring should be within controlled range. So if your controlled range is, let's say, pre-meals, you're looking at between 4 to 6, 2 hours postprandial, anything between 7 to 10. So then your control range will be between 4 to about 10. And your time in range, you're looking at 70% out. So 17 hours out of the 24 hours, you should have the values within that range. Then it means that things are going very well. So we're still talking about glycemic assessment. I've made mention of setting clear glycemic goals right from the beginning. It's very important, and you need to agree with the patient on this, please. We have to individualize the patient. When we set glycemic goals, what will work for patient A might not work for patient B. So you need to consider certain things. What is the life expectancy of this patient? Am I seeing a patient who has suffered some comorbidities? So you need to be less stringent for an older patient, a patient who had a stroke, a patient who is post-acute coronary syndrome, for example. You have to lessen your control a bit, because studies have shown us from ACCORD, from VATS, that when you tighten control in such individuals, they end up rather dying. So we have those where you want to be less stringent. So less stringent, long diabetes duration, 10 years and above, risks of hypos, okay, severe life-threatening comorbidities, like I mentioned, post-stroke, post-MI patients. The person is much younger, okay, fewer or no comorbidities, of course, you can be stringent with your control, and that will not create any problems for you. Pharmacotherapy for adults with diabetes. Now we have newer agents. Okay, it's not always about biguanides and sulfonylureas. Your choice of medication for a patient goes beyond glycemic target. It goes beyond A1C. You are looking at comorbidities. As I mentioned from the beginning, your initial assessment, you should be able to establish what other comorbidities the patient may be having. And that will inform your choice of drugs, because now we have newer agents that have cardiorenal benefits. It goes beyond glycemic control. And so your choice goes beyond A1C targets. Your choice, you want to prevent tertiary complications, as mentioned here. So that will inform the type of drug to use. There are so many combinations, okay? If the patient is having a heart failure, if the patient has a CKD, what stage? And your choice will be based on those comorbid conditions of the patient. Sorry, I'm rushing through my slides because of time. So lifestyle cuts across. Now, a patient with a heart failure or CKD, definitely you need a sodium glucose link transporter 2 inhibitor. Okay. And again, it depends on the stage of CKD. It's part of your medication. Okay. Now we are even using them in heart failure management, irrespective of glycemic status. Okay. If you think you don't have the competence, please refer to a colleague or confer with a colleague who can help. If a patient has established atherosclerotic cardiovascular disease, maybe peripheral arterial disease, chronic ischemic heart disease, a post-thrombotic stroke patient, any form of atherosclerotic cardiovascular disease, definitely one of your pillars should be an SGLT2, sodium glucose link transporter 2 inhibitor, or a glucagon-like peptide, okay, receptor agonist. You definitely will have to have that as part of, irrespective of A1C goal, you definitely will have to have that as part of your recommendation. If weight is an issue, you want to avoid medications that will make the patient gain weight, like sulfonylureas. You really, really want to avoid that. Okay. If the person hasn't got any form of insulin deficiency, then you try it again to avoid insulin, because insulin will make the patient gain weight. So where weight is an issue, you want to go for weight neutral medications or drugs that will help reduce weight, like GLP-1 receptor agonist. Semaglutide is a very good drug that helps reduce weight. We have newer ones like dulaglutide. They're a bit expensive. We have liraglutide around, which comes as Victoza. So we have certain medications that help with weight control. And so your choice is not just about reducing the glucose, but of course, managing other comorbids as well. I think I've spoken about metabolic associated liver diseases, so I'll not go back into it. Hypertension, very important. When it comes to definition of hypertension in diabetes, we are looking at 130/80 as the cutoff, okay? And the level of evidence is A. It is not 140/90 in the general population. It is 130/80, please, okay? And you need one or two or more at separate times to make a diagnosis. If at consultation, the BP is 180, 110 thereabout, that is more of an expert opinion. But if the BP is so high and you see the patient in, let's say, hypertensive emergency, of course, then you can make the diagnosis. Okay. So when it comes to BP control in diabetes, again, lifestyle cuts across. Lifestyle cuts across. But what we need to remember is that if consistently you have a patient with BP 150/90 and above, you need 2 drugs. Okay. And in blacks, what has been shown to work best for us are the calcium channel blockers and then the thiazides. The ACE inhibitors and the ARBs play a major role because hypertension in diabetes tends to be renogenic. You want to control the RAS system. So in your combination of medications for a patient with diabetes who has developed hypertension, one of them should be an ACE inhibitor or an ARB for the renal benefits. Okay. But if a patient has had hypertension for so many years before developing the diabetes, then most likely you may not be dealing with heredogenic hypertension. But if the diabetes is coming as a secondary cause from, if the hypertension is coming as a secondary cause from the diabetes, then most likely, especially when it's associated with microalbuminuria, most likely it may be renogenic. And your combination medication should definitely have an ACE inhibitor or an ARV. Okay. And the best diuretic, like indapamide, works best. Usually the thiazides from evidence don't do too well. Remember that the thiazides have the side effect of causing metabolic derangements. At higher doses, they cause dysglycemias. At higher doses, they cause dyslipidemias. So you want to avoid the thiazides as much as you can. If you have indapamide, then you are good to go. So that is it about hypertension. Okay. The role of statins. Statins are very important because they play two main roles: primary prevention and secondary prevention. In primary prevention, this follows what we call the CARDS trial, which is one of the largest ever done in type 2 diabetes. Okay, so we know that once the person is 40 years and above, you put them on statins, it goes beyond the lipid lowering effect. It also gives them pleiotropic effect. Okay, so it's able to prevent them from long-term atherosclerotic cardiovascular complications. So it is a must. And remember that diabetes alone is a major cardiovascular risk. So if somebody is 40 and above, the person already has a risk, plus the diabetes. Straight away, your choice of statin should be a moderate intensity. So you cannot put a patient on, let's say, atorvastatin. The patient has diabetes. The person is 50 years old and you are doing 10 milligrams. You are not helping that patient. It's a moderate intensity. Your stats should be 20 and your LDL target should be around 1.8 thereabout. So that is how you choose this. If you are not sure, please confer with a colleague, and I believe, but it's important. Don't leave a patient who is 40 years and above with diabetes without a statin. You're not helping that patient. That is for primary prevention. Okay. So when it comes to private prevention, what about those less than 40 years? They still have a role. So I'm seeing somebody 35 years, has diabetes. The person has hypertension, obese. That person is at high risk of atherosclerotic cardiovascular disease. Then you may consider, even though the person is not up to 40 years, you may consider a statin for. What is the role when it comes to secondary prevention? So for those with established atherosclerotic cardiovascular disease, you don't have to do any form of cardiovascular risk assessment. No. Okay. They have established. And for them, they need high intensity statins. So high intensity, if it's atorvastatin you are doing, you're looking at between 40 to 80. If it's rosuvastatin, you're looking at between 20 to 40. And for them, your LDL target is 1.4. So you do high intensity for secondary prevention. Once they have established atherosclerotic cardiovascular disease, if you're not meeting targets of 1.4, you can add on. Okay. What you don't have to do when it comes to statins. We've done this in the past, and I brought this slide up so that we don't. Please don't combine statins with fibrates. It's something people do. There hasn't been any evidence to point to the fact that it gives any added benefit. It doesn't. Okay. So if at maximum dose, you are not really achieving targets, the best drug to add on is ezetimibe. Okay. Or you can do, I don't have experience with the PCSK9 injectables, but they are around. Yeah. I hardly use them. Again, combining statin with niacin have not been shown to give any added benefits. Rather, it increases the risk of strokes and it has a lot of side effects. So stick to your ezetimibe, 10 milligram, in addition to your statins at maximum dose if you are not achieving target. Antiplatelets, another area of controversy. We used to give aspirin as primary prevention. Okay. It still has a role, but you have to individualize your patient. So if you've seen a patient with a very high cardiovascular risk, so let's say a 50-year-old diabetes, has hypertension, a smoker, obese, in such selected individuals, you may do primary prevention, but the role of antiplatelet is mainly for secondary prevention. mainly for secondary prevention. So the person already has established atherosclerotic cardiovascular disease. So a post-thrombotic stroke patient, a patient with peripheral arterial disease, for example, a patient who has had an acute coronary syndrome, they are candidates for aspirin. And the dose is between 75 to 162. Another thing I need to mention here is DUATs. People are doing a lot of dual antiplatelets where we are combining clopidogrel with aspirin. It's a very dangerous practice, and the evidence does not support it. The evidence does not support it. If you have a patient with established atherosclerotic cardiovascular disease, your low dose aspirin between 75 to 162 is just enough. Okay. Dual therapy has not been shown to really give. The only time you do clopidogrel are those that aspirin is contraindicated, GI side effects, allergies, then fine, you can do clopidogrel. Where a combination is recommended, then you are looking at your aspirin with low dose rivaroxaban, like 2.5. So you do 75, just like we do for patients with chronic atrial fibrillation. In peripheral arterial disease, instead of combining aspirin with clopidogrel, rather do aspirin with low dose rivaroxaban, like 2.5. The evidence is A. Okay, this has been proven by randomized controlled trials, reviews, and all that. So please, that practice of we combining aspirin clopidogrel for almost a patient with some form of atherosclerotic cardiovascular disease is highly discouraged because evidence does not support it. Okay, it's more of expert opinion. So if you look at it, it's E. Okay, right. Great. So for undiagnosed cardiovascular disease, we don't screen routinely, but for those that have symptoms, so you see a patient with peripheral arterial disease, for example, then you may want to do your calcium score, or you may want to do your carotid Dopplers, for example, or maybe want to do an MRA, but we don't go screening routinely for coronary artery disease unless they have symptoms. So if you see a patient with PAD, then you want to look at for others. Heart failure is recommended, especially if you've seen a patient with 5 years history of diabetes or at the time of diagnosis. Your pro-BNP is just enough, okay? And you can add on an echo. Pro-BNP, fortunately now, a lot of labs are doing it, so it's not so expensive. Heart failure, you have to screen for, okay? Peripheral arterial disease, again, if there are symptoms, you can just screen with an ankle brachial index, something we can do. With a simple cuff, you should be able to do that. So coronary arterial disease, we don't routinely screen for. But if there are some symptoms or pointers, then you may want to. Okay. Okay. So I've been talking for the past almost 55 minutes now. I'm happy I'm within my time. So the take-home message is that for us primary care physicians and any other care providers who are online, we must be aware of these evidence-based guidelines as we've spelled out and align our approaches to diabetes management with these evidence care models. The second thing is that these models emphasize patient-centered, team-based approach. So it is not a one-man show. Diabetes care goes beyond just physicians. You need everyone on board, and it should be integrated and well coordinated. I want to say thank you for the opportunity.
Thank you very much. Thank you very much.
Thank you very much, Dr. Francis. And I can see the passion with which, he tackles diabetes, so passionate about diabetes. And I can see a lot of questions coming in. But one very strong point that is put out there, because a lot of people be going like, which medication do I start with? But it says that the medications is based on a lot of factors, which one to use. That the patient is the patient not to have a heart failure, is the patient not to have a chronic kidney disease, does the patient have other conditions for which some other medications could be a first line, But there's a question that is in. I think when we get the question time, we will take a look at that. But as I said, we have our sponsors with us, Gates Pharma. I mean, since they came, we've been collaborating and they've been great collaborators and partners. And today they are here with us again. And they're going to give us a 15-minute presentation. As Dr. Dai was presenting, I could see them nodding and nodding and nodding. So they want to tell you that their medication that they have for you is also evidence rating A. So as it goes on, you can also align with some of the evidence-based guidelines that Dr. Ade was putting on. Get Pharma, please take over.
Okay, so unfortunately or fortunately for our patients who were not able to manage their pre-diabetes very well and now have been diagnosed with diabetes, I've come here with some good news. My name is Dr. Andy Kobna-Edison. I'm with Get Pharma and I'm here with my country manager, Asantoan Ponsa. So in a heartbeat, Get Pharma is a US affiliated Pakistani company. We are currently one of the best generic companies you can ever find. In Africa alone, we are present in 11 countries, of which Ghana is a part of. So in Ghana, we major directly with asthma and diabetes management. And for the purpose of our gathering here, we'll just briefly talk about our diabetic medication. So we have what we call Trivia and TriviaMed. So Trivia is the molecule sitagliptin. It's a DPP4I, which means a dipeptidylpeptidase 4 inhibitor. And you know the other classes that are present, like the Vilda and the Lina and so forth. But one interesting thing about the Trivia or sitagliptin is that it's the most extensively studied DPP4I that we have. And that assures us of the safety that is guaranteed with the medication. As well, it has the longest half-life of all the classmates in its class of about 14 hours, whereas the others have a maximum half-life of about 5 hours. So which means that it allows our clinicians to do a once daily dosing monotherapy if need be. And this tends to reduce the pill burden for our patients. The other interesting things we can look out for our Trivia, and that is the fact that it's able to be taken with or without food for the questions that our patients usually ask. And that's because the bioavailability is non-dependent on whether the patient has taken food or not. Now, when it comes to the big question of hypoglycemia, as it is seen with other anti-oral diabetic medications like the SU, our Trivia has shown to have zero risk of hypoglycemia. So if you and your patients are concerned about it, Trivia is the way to go for that. Now, when it comes to weight, as we had our presenters speak on, our Trivia has been shown to be weight neutral. So if your patients or yourself are concerned about your patient gaining weight or losing weight, Trivia is the way to go. We also spoke on the comorbids that affect our patients who are battling diabetes. So when we come to the issue of cardiovascular events, our Trivia has been shown to have neutral effects on the heart. As well, it's been shown to improve certain cardiac responses. So the issue of having free radical activity and oxidative stress, our Trivia has been shown to be able to help our patients with that. And we cannot miss the fact that our diabetic patients tend to end up with the comorbid of renal insufficiencies. Per the guidelines and per the studies that we have conducted, Trivia can safely be used in patients with renal insufficiencies. When we dash further, we can see that some patients will fall in several classes of renal insufficiencies. And with our Trivia, it is backed by the guideline that if the patient goes into a category of moderate to severe, we advise that we halve the dose from the initial dose that we started. I would also want to mention that Trivia comes as in a strength of 50 to 100 milligram. So if our patient is put on 100 milligram and they get to a renal insufficiency of moderate to severe, we would want to taper down to half of it, which is 50 milligram. So that category will be when their eGFR is being recorded for about 45 mil per minute. Now, we also know that not just one anti-diabetic medication is able to tackle all the pathophysiological defects that diabetes comes with. So the guidelines recommend that an addition of metformin or a dual therapy is highly recommended. By reason of this, Guess Pharma has brought into being what we call Triviamet. So Triviamet is a combination of sitagliptin and metformin, and that exists as 50 by 500 milligrams. So that's 50 milligrams of the sitagliptin and 500 milligrams of the metformin. And we have a higher dose, which is the 50 by 1,000 milligrams. So with that, the interesting thing about it is that it's been shown to reduce their HbA1c with a difference of about 1.24%, which is really significant as clinicians in as little as 3 to 6 months. So that has given us a lot of results and a lot of patient satisfaction. We want to see the science and the phenomenon that is bringing about all these great and desirable effects that I have mentioned, and that can be seen with the mechanism of action. So in an ideal state, when your patient takes in food, the GIT releases what we call incretins. And these incretins are what stimulates the beta cells to produce insulin for us. But we have an enzyme within the system called the DPP4, which is the dipeptidyl peptidase 4 enzyme. And what this enzyme does is that it truncates the level of the incretins to about half of its original level. So the level that is remaining in an ideal person who does not have diabetes is sufficient to produce enough insulin to control their glucose. But if your patient is diagnosed with diabetes, you wouldn't want to have the amount of the incretins that are present in the body. So that is where Trivia comes into being. When Trivia is ingested or when Trivia is taken, it now prevents the action of the dipeptidyl peptidase 4 enzyme. And when that happens, there's a 2 to 3-fold increase in the level of the incretins. And when that has been put in place, we'll have sufficient insulin release for our patients to manage their glucose very well. And we highlighted the fact that hypoglycemia and its incidences being reduced is one of our strong bargaining points. And that is because of the mechanism of action that I stated. So unless our diabetic patient is in the range of hyperglycemia, sufficient insulin will not be released to tip the patient into hypoglycemia. So if your diabetic patient is in normal glycemic range or hypo, you wouldn't have Trivia causing enough or more insulin release to tip the patient into hypoglycemia. And as I said earlier, not just one anti-diabetic medication is able to tackle all the pathophysiologic defects for managing diabetes. So there comes the combination with metformin. So as Trivia in itself being sitagliptin, increasing the levels of insulin, then we also have metformin sensitizing the insulin to drive glucose into the cells and making energy available for our diabetic patients. So with some of the clinical studies that we've done, we noticed that when Trivia and Triviamet was used in as little as 12 weeks, we had a difference of about 1.05% reduction in their HbA1c, and that is highly remarkable for us, and we would love to use this for our patients when they come to our consulting room. So we mentioned in Dr. Dora's presentation where Ms. Pio came with certain values of her glucose level where she was pre-diabetic. In case we do a follow-up lab and she's now diabetic, we want to encourage and prescribe Trivia and Triviamet depending on the clinical situation that she's presenting with. Not to forget, Mrs. P.O. may not come alone. She may come with her husband, Miss P.O. So we want to do a holistic check. We can encourage him to also check his glucose profile. Unfortunately, if he falls into the diabetic category, we can introduce Trivia and Triviamet to him depending on his clinical situation. We mentioned the fact that a complication of diabetes is erectile dysfunction. Because we don't want any problem at home and we want to tackle it from the get-go, let us put Mr. P.O. on Trivia or Triviamet depending on his clinical situation. So thank you very much. This It's a brief presentation of what we have. Trivia and Trivia Med is available in most pharmacies that we have, especially around the hospitals. And we are inviting all our doctors and clinicians to put this to test, and we assure you of massive and great results. My name is Dr. Anikobna Esin from Get Pharma, and I leave you with Trivia and Trivia Med. Thank you very much.
Thank you very much, Get. Now, normally when you are presenting on medications, the questions are flowing on it. So as you go into the question and answer time, I'm going to start with you. So one of our clients saying that yes, DPP-4 is a very good medication with trials, and especially in environments where we are concerned and with hypoglycemia and also with the postprandials, which are going high and want to use it. So it's asking that what's the cost of Trivia Med? I mean, because it's very good. Can our patients afford it?
Yeah, so our product Trivia Med is highly cost effective. You should get it between 240 to 245 cedis, depending on the location and the markup that the pharmacy uses. So basically, that's the most popular brand in price.
Okay, thank you very much. So you said that it's going around 240 at the retail, at the wholesale probably around 180.
187, yeah.
Yeah. So that is what our clients are going to have it on. So if it's catered for, which is catered for most of our clients with diabetes, the name is Trivia Med. Dora, so somebody's asking that these days our clients don't even want to start the medications, and you happen to convince them to start, and they get to consistently between 4 and 6, and they come to you the next consulting day singing songs of praises and saying that, Doc, I'm going to stop my medications. It says that, what should you do? What's your take on it?
All right, thank you very much. So I want us to remember that beyond glucose lowering, we have to consider the global cardiovascular risk. So we sometimes are a bit glucocentric. We think it's only lowering your blood glucose that is the important thing, but it's not. And as I was saying earlier, the major causes of morbidity and mortality in diabetes are cardiovascular diseases, atherosclerotic cardiovascular disease. So you'd need to do a global cardiovascular risk assessment. Does the patient have hypertension? Does he have dyslipidemia? Does he have chronic kidney disease, heart failure, obesity? Before you start that discussion on whether they need some reduction or down titration of their medications. That's for even pre-diabetes. For someone with type 2 diabetes, it's a difficult call to say, go off your medications, because we know the metabolic complications that occur just simply because of the hyperglycemia. So I wouldn't recommend that, except I know that in pre-diabetes, if you're able to sustain a lifestyle of diet and exercise 6 to 12 months, and your HbA1c comes down, you may be able to let the person maintain the lifestyle depending on the risk. So it's not a very straightforward answer. But what I would like us to take away is that we should always assess the global cardiovascular risk of the patient before we take any such decisions. Thank you.
Thank you very much, Dora. So you're saying that assess, because as you were just answering, somebody brought in that is where that type 2 diabetes can be reversed. And so, I mean, when do we say that there's reversal?
So there are studies to show that you can drive diabetes into remission. So remission is probably a marking time So you're saving time. And if things don't go well, you become obese or other risk factors creep in, you may tip back into diabetes. So you can remain in remission for a while. But what was the question again, please?
So, I mean, the person saying that is read about reversal
Right.
of type 2 diabetes. So when the client comes in, and sometimes when they come in, some of the education is that, or if you should do your lifestyle and other things, well, you could reverse. When do we say that there's reversal? And they don't need to take medication, but probably manage with lifestyle.
It's a good question. I wouldn't put a value to it. I think my big brother would be able to help me there. But as I keep saying, that it's more, the word is more of remission. You would sort of stall the effects of the condition, keep them within a good glycemic range. And that can be for several years. As to saying that this is at the time T where you're in remission and you remain there, I'm not sure I can answer that. I would want Dr. Adai to help me with that. Thank you.
Yeah, thank you. Thanks for the question. I just want to add my voice to what Dr. Epidemiology said. So for every disease state, which includes diabetes, we prefer to use the word metabolic disorder than diabetes being a disease. So for every metabolic disorder or disease state, please let's remember 4 things, okay? The first one is a genetic predisposition, which is your family history. The second one has to do with your behavior. So behavior, like we mentioned in primary prevention, the things you do, lifestyle and all that. And then the third thing is your environment. So your environment can play a big role. And then the last or the fourth pillar is your physiologic state. And your physiologic state is an interplay between your genetic predisposition, your environment, and then your behavior. So whether you be in remission forever is based on these other components. And that is what she emphasized on. So primary prevention, we are looking at what you eat, your activity level, what you are inhaling, what you are smoking, what you are drinking. All of them work together to determine your physiologic state, which eventually will lead to your disease state. So you can be in remission, but the challenge sometimes is the maintenance, how to maintain and sustain the gains you've made. So if you relapse, and let's say, like she said, you gain weight or you're overeating, you are no longer active, you go back, you relapse. Okay, so it's difficult to put a timeline to it. Someone can be in remission forever, and the person may not develop that full-blown diabetes anymore. Someone may be in remission for 6 months, 1 year. Don't forget that diabetes is a chronic metabolic state. The fact that you're in remission doesn't mean it is cured. We don't cure diabetes. You can be in remission, but it doesn't mean it's cured. So if you begin to do the wrong things, then you definitely will relapse. Okay. So that's what I wanted to add. Thank you.
Thank you very much. Thank you very much, Dr. Adai. So in effect, if you're going to remission, don't let your patients go into hiding for years, only to come with just monitor them and make sure that they are going on with their lifestyle modifications and close monitoring, so that if they are relapsing, they can find out early and support them. Get Farmer, people have questions for you. So what's the difference between your Trivia and Trivia Med? And they're saying that what are the major side effects of Trivia? If you can take that.
Okay, thank you so much. So the difference between Trivia and Trivia Met is that Trivia is just the plain molecule, which is sitagliptin, and it comes as 50 milligram and 100 milligram. I just want to add that the maximum dose of the Trivia is 100 milligram. So once daily dosing is appropriate. Trivia Met is a combination therapy of sitagliptin and metformin that also exists as 50 by 500. So that is 50 milligram of the sitagliptin, 500 milligram of the metformin. Then we also have the higher strength, which is the 50 by 1000. So 50 milligram of the sitagliptin and 1000 milligram of the metformin. That can also be used once or twice daily, but twice daily is the most preferred by the guidelines and our clinicians. So when it comes to the side effects, we've recorded really low incidences. Most are very general, as with every other medication. Just that with the metformin, because of the inclusion of the metformin, people tend to have the GI side effects like having diarrhea and all of that. And all those incidences are low. And I just want to add on to the fact that when you are using the Triviamate, just because of the addition of the metformin, if your patient records an eGFR of 35 ml per minute, you would want to safely withdraw it only because of the metformin. But if you are using just the plain Trivia, those adjustments is highly recommended and you are good to go. Thank you. I hope that answers the question.
Thank you.
Thank you very much. Doa, I think people are finding issues with oil. So they are saying that unhealthy oils, seed oils, plant oils, so many oils. So they are asking that unhealthy oils, somebody saying seed oil, how do you differentiate between these ones and which ones are good in terms of lifestyle?
Well, so for the oils, would want to stay away from saturated oils or saturated fats. And many of the oils that we have in our local context have saturated fats. So palm oil, palm kernel, coconut oils, and those oils which require high heat processing are also implicated. So the recommendation, I think, would be to limit the use, if you can avoid the use of these saturated fatty oils, then go ahead and not use them. The coconut oils, palm kernel oils, reduce your intake of the palm oil. And then the seed oils. If you can, and I know it's not, a very cost effective thing, but if you can, rather do canola oil or olive oil. But I think it's also recommended that if you can do without that. So people have learned how to make very good meals without oil or limit the quantities of oil they use. So I think that it's sort of a balancing act, since these are the sort of cheap and affordable ones that we have. We can limit their use and then avoid the ones which are saturated as much as we can. Thank you.
Thank you very much, Doa. So yes, somebody is asking that Dr. Ade was mentioning big names and big medicines, which he has not heard or found some at the district or at the health centers. So somebody is asking that, what's the place of the glimepirides in the management of diabetes? And those are the districts where they can find these big medications that you are mentioning. What should they do? And what are we doing to make sure that they also have access to those ones and they can also be able to prescribe them? Dr. Ade.
Thank you, my president. And thanks for the person who asked the question. I've actually typed in something, but glimepiride is one of the intermediate acting sulfonylureas, as we call them. And sulfonylureas are insulin secretagogues. What it means is that they work at the level of the pancreas, specifically to stimulate the beta cells to produce more insulin. So you need a functional or some amount of residual function within the pancreas for them to work. The disadvantage, unfortunately, is that we know that majority of type 2 diabetes patients at the time of diagnosis have already lost some amount of beta cell function. So in some category of patients, these sulfonylureas, of which glimepiride is a member, don't work too well in patients with type 2 diabetes. They are affordable, but to be honest with you, if you look at most current guidelines, they are hardly even mentioned. But in our part of the world, and then where some of us find ourselves in low resource setting, we are still compelled to use them. So you can be forced to use it, but unfortunately, it's not one of the best, especially in older patients and then in patients with depleted or wane of beta cell function. It wouldn't give you the results that you need. They are okay to use, but the main side effects are, one, risks of extremely reduced sugar levels, especially when you use them in combination with other drugs. And then also they have the side effect of weight gain, especially if the person is taking it and the person is not too active. So those are some of the challenges. It's unfortunate that we still battle with health financing in our part of the world. It's just in Africa and therefore Ghana where we see that disparity, that someone is in a remote place, let's say in Prayaso, where I used to work, all the way in Kwewu, TB in Prayaso, and someone is easily gone. The person has access to everything, but the person at in Prayaso is not having access to. It's unfortunate, but we're praying and hoping that we bridge that gap, because when it comes to health financing, universal health coverage that we're all preaching, there shouldn't be that gap between where you find yourself. So location should not deprive you from getting the best of care. But unfortunately, that is what we have in our part of the world. I can't give a definitive answer because it's challenging. I wish you have all the medications wherever you are. But for those who need it, I'll say that refer maybe to a higher level, to the tertiary facility where they can get, because the person may be in need of the medication for other benefits beyond glycemic control. Thank you.
So somebody has brought it that. Yes, in terms of your management, you were talking about managing according to probably some other comorbidities that there may be. If you diagnose somebody with diabetes with no apparent other comorbidities, what are the available anti-diabetics that are there that you can use? Which one should you start first?
All right. So, Mr. President, thanks for that excellent question. So if you diagnose someone with type 2 diabetes, you've done your cardiovascular risk assessment, you think that the person has an ideal body weight, lipids are not too bad, renal function is fine, you were fortunate to do some ECG, ECG is fine, BP well controlled. If your A1C is not above 8.5%, you can do monotherapy. If it's, let's say, 8%, your target is to drop that 8% to 7% and below, which you can achieve with one drug. So your first drug may be metformin, unless metformin is contraindicated. Okay, so your first drug may be metformin. If that patient, unfortunately for you, has, let's say, a metabolic associated liver disease, for example, from maybe your liver function, you realize that the transaminases are up. You had access to ultrasound and they tell you that, oh, it's a grade 1 or grade 2 fatty liver disease. Then, of course, such a patient, you may not be able to use metformin for that patient. And those are the kind of patients you may need other drugs for. If the A1C is above 8%, let's say 9%, So 9%, then you want to reduce the A1C up to about 2.5. So you need dual therapy. If there are no contraindications, then you can add on to that metformin. We just heard about vildagliptin. The DPP-4 inhibitors are there. We have vildagliptin, sitagliptin, they come in combinations. You can, if that person is not obese, you can also add on a sulfonylurea. But I like to use sulfonylurea in much younger people than older people. If you do these combinations, and let's say 3 to 6 months, the sugars you are monitoring, you are not achieving target, then you have to change. The first drug you want to change will be the sulfonylurea. Most likely, that person has some amount of depleted beta cells, and therefore your sulfonylurea will not work. So you maintain the metformin, but you have to definitely add on another drug. The only drug that works independent of insulin now that we know are the SGLT2 inhibitors, what we call the sodium glucose link transporter 2 inhibitors. They work at the level of the kidneys, the nephrons. Okay, so they block the reabsorption of glucose back into circulation, and they work independent of insulin. So in such patient where you suspect them to be having depleted beta cell function, then if you have access to an SGLT2 like dapagliflozin or empagliflozin, then you can add that one onto the metformin, and it's likely to work for you. Okay, yeah. So that would be it's unfortunate, but ideally from baseline, you should know the patient before you. But please remember, the time didn't allow us that the natural history of type 2 diabetes is that it's a progressive metabolic disorder. So with time, for most patients between 5 to 10 years into being diagnosed, they may be at stage 3 phase of type 2 diabetes, where they have just about 25% of beta cell function. So your sulfonylureas may fail you, and most of the orals may fail you. If you have access to insulin, you can add insulin to the metformin. Okay, but when you have a challenge, you can seek a second opinion. Thank you.
Thank you very much. There's a thumbs up here that at least you've gone to what they know and how they should move. So it says that if there's no comorbidities and other things, yes, and the HbA1c is 8. I mean, you could start with your metformin, you could add up with your DPP. I mean, I think the trivia comes in, trivia med comes in, and of course you can add other things. But it seems that because of the depletion of the beta cells, I mean, you should be careful with your sulfonylureas. And of course, if they are not doing well, other ones are there. The SGL2 are there. You can add your insulins and all that. So all those ones are there. But always remember that if there are other comorbidities, then your choice of your medication may change a little bit. Thank you very much. Doras, this comes to you. It says that for morbidly obese people with hypertension, diabetes, say 50 years and over, with obvious walking difficulties, how do you counsel these people to exercise? It says that he had one in the consulting room, everything, and with osteoarthritis of the knee, confused. What should I do? The next one says that for weight management, is there a timeline to lose the weight? Say lose 10% over 3 months. How should you work with the client in terms of the percentage of the weight that they want to lose? Dora.
Okay, so that's quite challenging, isn't it, for someone with comorbidities and osteoarthritis, making it difficult for them to exercise. So swimming, well, I mean, I know Ghanaians may not really like water, but if you swim, it may release the stress from your knee. Remember, muscle strengthening exercises too are useful. So if you have dumbbells, you can, lift at least your arms, you can lift the dumbbells. Coordinated care as well, because if you have osteoarthritis and it's causing you to have reduced activity, then it means you need to be seen. So the person would need to be seen by an orthopedic surgeon. Is the person requiring knee replacement or some analgesic therapy to relieve the pain? Okay, so I don't think we should just say that because a person has osteoarthritis and pain, that should limit the person's activity indefinitely. So care should be sought. So coordinated care with, is it an orthopod? And sometimes even the physiotherapists are able to help in managing people like that. So exercises that may not put stress on the knees, muscle strengthening exercises, seeking care for the other conditions that limit exercise, that would also help. And then diet. So dietary reforms, that one you can do quite easily. So coordinated care, your medical nutrition, your orthopedic specialists, your physiotherapists, all of them will help manage this patient.
Thank you.
And then the weight loss question. So the weight loss, I think, should be very gradual. If you rapidly lose weight, there are also other complications that can occur. You can get gallbladder disease, and most often that drastic weight loss is not sustainable. So you quickly lose the weight, and then your body sort of starts craving all the things that you deprived it of. So as quickly as you lost it, you would quickly gain it back, and if not more. So it's more of a behavioral change. So you change how much you're eating gradually over a period of time. And your body now gets used to a reduced quantity of food, etc. Sometimes someone comes and says, oh, you have to exercise. And immediately they want to jump and go to the gym. But you need to tailor it to the person. I mean, you have to go gradually. So it's more of a lifestyle change and not a magic, wand that. But if you lose about 0.5, 0.4, 0.5 kilos a week, if you are able to, that will help. But drastic things do not usually cause change in behavior. So I wouldn't recommend that.
Thank you very much, Dora. Dr. Ade, this is a very difficult one coming. Erectile dysfunction is a major issue when it comes to men. And I mean, that's the only time that you can have an 80-year man actually tapping you and saying that, my son, I need to discuss this. I mean, how do I deal with this? So somebody's asking that you have such a client and you've done all you can. You've controlled your sugars and done everything, and the ED is still there. What should you do? If you can help us.
Thank you for the opportunity, and thanks for whoever asked that question. I must say that we know that diabetes is a cause of erectile dysfunction because of the neuropathic and then vascular complications. But the bulk of ED or erectile dysfunction, the cause is psychogenic. So in practice, we know that some of the majority of the cases that come to us in consulting room with issues with erection, they actually don't have diabetes at all. And that is why in the initial assessment of a patient with diabetes, you need to find out about sexual satisfaction. You need to evaluate that from the beginning. So the distress of the diabetes itself can give the patient those psychological issues. And so they lose interest, but not that they're suffering an organic cause of the erectile dysfunction. So it is important to assess and assess well. Sometimes one of the easiest way is to, in the good mood of the patient, you can let a partner arouse the patient and see if indeed, or ask about early morning erections, for example. Somebody with erectile dysfunction may not have early morning erections. So you need to evaluate and make sure that the erectional dysfunction you are dealing with is not psychogenic. Okay. Because like I said, the majority will come from psychogenic rather than the diabetes itself. And that is why in assessing our patients and evaluating them from the beginning, the psychosocial care is very important. You need to find out about diabetes distress. You need to find out about anxiety. You need to find out about all that and then establish that from the beginning. So patients who live with a chronic condition will always need some form of psychological support. So establishing whether indeed you are dealing with an organic cause or a psychogenic is important. If you're able to establish what it is, if your psychological support is not working, you can always seek or coordinate the care of that patient to see a urologist, okay? And further evaluation can be done. But please, let us be careful of giving some of these aphrodisiacs to patients. And remember, sildenafil and its families have a serious side effects on the cardiovascular system. So if you have a patient with diabetes who may be having some underlying cardiovascular disease, a heart failure, chronic ischemic heart disease, and you go and prescribe sildenafil 50 milligram at night, please be careful. You're going to tip that patient into something you don't expect. Okay. So bottom line, please establish what you're actually dealing with. Is it a psychogenic thing or is it indeed an organic problem? And therefore, you may need to coordinate the care to see a urologist.
Thank you very much. Thank you very much, Dr. Ade. I'm just going to ask the last series of questions because of time. We already 5:30, and as we promised, we don't want to go, beyond the time. Dr. Ade has promised his number out. I've seen, a question out there about a case that somebody may need support in taking care of the client. So I'll put Dr. Ade's number, Doris' number online so that, you can call them to support you in these ones. But Dora, they are asking about sweetness. What's the place of sweetness? In the diet of clients. And somebody is saying that somebody who's not to have pre-diabetes and the lifestyle, it's not ready to have, to do any lifestyle, or it's not able to really do the lifestyle modification well. What's the place of medication in this group of clients? So these two questions. The sweetness.
Okay, so sugar intake is actually an acquired taste. And for most people, when they stop using added sugars, they realize that it's not a big deal after all. However, what I know about sweetness are that some of them actually change the gut microbiome. And so in some articles I have read, you realize that because the gut microbiome actually changes, even with people who don't have diabetes, they may actually develop diabetes because they're using sweetness. I know there are a number of branded sweeteners that may be safe to use. I don't know if I'll be marketing it for them. So I think I would rather not mention the brands, but I know there are some that's, are relatively okay. I wouldn't say I have the evidence to support their use, but one of them has been touted to be relatively safe to use. But sugar is an acquired taste. You can unlearn how to use it. So that's the first one. And then the second one was if someone has pre-diabetes and doesn't want to do lifestyle or is unable to. Well, with these evidence-based studies, one of the supports that the individuals were given was regular polls, regular monitoring. And for some of them, within a period of about 24 weeks, you had been called about 16 times, because these things are not very easy to do. And it takes time for one to decide, in the cycle of change, to decide to embark on a new behavior. So I would say that even if the person is currently not happy to start lifestyle change, continue reinforcing that. There will be a time where the person will move from the pre-contemplation to contemplation and actually action. Support groups are also a deal. Referrals to places that, encourage these exercise and lifestyle. I'll come to the medication because I want it to be the foundation to be your lifestyle modification first. Then there are indications for medication. So for someone who is obese, right, BMI more than 35, more than 30 kilograms per meter squared, and other risk factors, and then impaired fasting, you may want to give a GLP-1 receptor agonist so that, you help in the obesity as well as prevent them from getting diabetes. Then for someone who has had gestational diabetes, who is in the impaired glucose tolerance or impaired fasting glucose range, age less than 60 years, BMI about 35 or more, you can consider among exercise, diet, weight loss, metformin. But you also need to look out for the other reasons why one person may not be given one medication or other, because of, we have kidney disease, we have a lot of comorbidities. So this would be my answer to them.
Thank you very much, Dora. She started with lifestyle. She said that try, work on this client, check the stage of change and work on these clients as much as possible. Work with the client to do the lifestyle. There might be some indications. You can look for those indications, and if the indications are right and there's no contraindications, then you could consider. Dr. Ade, your last series of questions. So somebody was talking about sleep at night. What about sleep during the day? Good sleep. And somebody's also saying that you mentioned that screen time can lead to complications in DM and even weight gain. What's the evidence and how does it happen? And the last one, he talked about your dual antiplatelets, and he says that there's evidence that in acute cardiovascular diseases like MI and CVAs, in fact, if you could do the dual for 21 days, has it changed? So if you could take these three quickly for me. Or are you talking about the long-term antiplatelets? Thank you.
Right. Thank you for the questions. So I'll start with the sleep. In fact, we have people who work at night, so they sleep during the day. The time of the day depends on your setting, what you do. But the most important thing is the recommendation is to have an 8-hour sleep in a space of 24 hours. But within these 8 hours of sleep, you need deep sleep, which is about an hour and a half to 2 hours. So within that 8 hours, you may have those shallow phases where people knock at your door or somebody moves and then you wake up. But a deep sleep within the 8 hours is so key. The second one, I remember the third one, which is the dual. The second one is screen time. Yeah, so we know that increased screen time causes, we know there's evidence to support it, causes sleep abnormalities. It's established. Okay, so what is recommended is whilst even trying to sleep. If you're not able to sleep, then read. But the reading is not on a screen. So you read something from a book, and then if the sleep comes, you go back to sleep. The interface between your brain centers, neurons, and then the screen is well established, whether you're using computer, you're on your phone, tablet. So screen time and sleep abnormalities, the relationship is well established. Okay. The third one has to do with dual antiplatelet. The recommendation.
The screen time, we're linking it to control DM and weight gain.
Okay. So you can link screen time to weight gain and diabetes. I think what is important there is sedentary lifestyle. Okay, what we know, especially in adolescents with type 2 diabetes now, is it makes them sedentary. So you have people sitting behind the television and playing games without getting up. So the recommendation now generally is that within 30 minutes, maximum 1 hour, you need to get up and walk. But people who sit behind TVs and then play games at high risks of weight gain, and then you can link into cardiometabolic disorders, but not screen time per se. But if you sit behind a screen, what you can link to weight gain is more of sedentary lifestyle. Okay. With a dual antiplatelet, more harm has been caused. In fact, where dual antiplatelet currently, in terms of evidence, is recommended in patients who get CABG, okay, bypasses. So in the area of cardiology, there's some room there, but not in other conditions like thrombotic events from diabetes, peripheral arterial disease, thrombotic strokes, and the rest. No, the current evidence is not for it. Aspirin has been shown to work for secondary prevention, but where aspirin is contraindicated because of GI side effect, because of allergies, then of course you bring in clopidogrel. Where an addition is recommended, then that recommendation now is that you do aspirin with low dose rivaroxaban, and the evidence is A. So the dual antiplatelets in the slide that I showed, you realize that it's expert opinion, it's E. An expert opinion, you cannot run with it. So that'll be my answer. Thank
And
you.
the question that it came in is, are you talking about the long term or the acute phase, or you're talking about all the phases? So, I mean, it's saying that in this, I mean, a lot of them from some guidelines that in the acute phase of it, first 2 weeks, 3 weeks, there is a place for it. Is it that those ones?
Those are older evidences. So some of the older evidences, you can do what we call high dose aspirin, where you can even do 300 milligram for 2 weeks and then dual but bleed and complications. So if you look at, in fact, what I presented today is the 2025 guidelines, and that sees it more like expert opinion than following randomized control trials, because more harm has been caused by that. So even in the acute phase, talking about both primary and secondary prevention, okay, what the evidence is for, you can do aspirin between 75 to about 162. If you fall within that range, the aspirins from America, the enteric-coated comes as 81. There's the 100, and then what is common on our market is the 75. Okay.
Okay, thank you very much. I hope your question has been answered. Your last words. So I'll start from Get Farmer. Your last words, just 30 seconds on your last words.
Okay, thank you so much. Our last words is that Trivia and TriviaMet is now the way to go. If your patients are suffering or are battling poorly controlled glucose levels and are type 2 diabetes mellitus, do not hesitate to give them Trivia or TriviaMet depending on their clinical presentation. And I can assure you that you would get massive results. Thank you so much.
Dua, your last result.
Okay, so let's just remember that the prevalence of diabetes is increasing. That, as well as the prevalence of pre-diabetes. Prevention can lead to avoidance of macrovascular, microvascular complications and other cases of mortality. So let's screen our patients. Let's offer them the right lifestyle recommendations, and let's keep the patients in a loop. Let's not lose patients who are found to have pre-diabetes because they are just one step away from getting diabetes. So prevention is key. Thank you.
Thank you very much. Dr. Ade, your last words.
Thank you for the opportunity. So, diabetes management or care goes beyond glucose lowering care. It has to be comprehensive right from the onset. So our initial evaluation and assessment is key. We should be able to classify the type of diabetes we are dealing with, evaluate the glycemic targets, and then agree on the long-term care of the patient. And what has shown to work is the team-based approach. Don't do it alone. Get everyone on board, and let's ensure that our clients get the best management and care. Thank you.
Thank you very much, Frances, Dora, and Get Farmer. And thank you, our audience, for staying on. We still have over 800 people who have joined in constantly on our YouTube, and also on Zoom. And we really appreciate your presence with us throughout. Just a few announcements. So Dr. Francis Ade has put his number online for those who put those questions on, the lengthy questions on with cases. His number is 020-630-0805. I go again, 020-630-0805. So you can kindly connect with him and he can help you with those cases. On this note, every primary physician, every family physician should know that next week, Tuesday, all the buses and all the flights are headed towards Tamale. All the buses and all the flights are headed towards Tamale. We are moving on Wednesday, and on Thursday, we are starting our AGM. But before that, on Tuesday, we are having our mega medical outreach at Tamale. All our members within the northern sector should make sure that they are part of this. Normally, we see over 1,000 people, so make sure that you are there with us, those in the northern sector, so that we can support with this medical outreach. And all of us should make sure that next week, Wednesday, we join the bus, we join the flights to Tamale, where we have our AGM. On Thursday, we're going to have another CPD at the AGM, and let's, make sure that we join in and let's share so that all primary physicians can join in this one. On this note, I want to say thank you very much, Get Pharma, for supporting us, and thank you, our audience, for staying on with us. Thank you, my technical team. Thank you, my in-person audience who are with us. Thank you, everybody. Have a nice evening, and hopefully we all meet at Tamale. Stay blessed.